Thank you, Madam Speaker. Madam Speaker, I ask unanimous consent that all members may have 5 legislative days in which to revise and extend their remarks and include extraneous material on the subject matter here tonight. Madam Chair, thank you for allowing us this time tonight to talk about a very important subject. As many of you know, currently I'm the only pharmacist serving in Congress, and that is something I take very seriously. Two of the things that I really wanted to concentrate on when I became a member of Congress, among many things, but two of the main things were, first of all, prescription drug pricing. And that's one of the things that we want to talk about here tonight. The other thing that I wanted to concentrate on was the opioid epidemic, and we've been very successful here in Congress in addressing that issue. But tonight I wanted to talk about prescription drug pricing because I've witnessed it. I've witnessed what I would describe as truly a crisis. I've witnessed years of practicing pharmacy. I've seen families struggle to pay for their medications. I've seen senior citizens at the counter across from me try to make a decision between buying medication and buying groceries. I've seen mothers literally in tears because they couldn't afford the medication for their children. When I came up to Washington, that was one of the things I wanted to concentrate on. We're very fortunate we have a president and an administration that's focused on this issue as well and has done some outstanding things. Two of those things that are being proposed by the administration right now I want to talk about tonight. But the main thing I want to talk about is the prescription drug chain. Just earlier today, we had a hearing in the Energy and Commerce Committee and the Health Subcommittee that I serve on, where we had representatives from the pharmaceutical manufacturers and from the PBMs, the pharmacy benefit managers, pointing fingers at each other, blaming each other for the problem. Now, I have to tell you that in full disclosure, I'm big a fan of the pharmaceutical manufacturers. What I have seen over my years of pharmacy practice has been nothing short of phenomenal. When I first started practicing pharmacy in the early 80s, I can remember a time when if you needed an antibiotic, you had to take 40 tetracycline. You had to take 4 a day for 10 days. Now, you can take an antibiotic or get a shot in 1 day and be cured of some of the things that we were treating back there in 1980 with a 10-day supply. I've seen illnesses such as hepatitis C. Hepatitis C, when I first started practicing pharmacy, was pretty much a death warrant. If you were diagnosed with hepatitis C, you were probably going to die. Well, I've seen through research and development of the pharmaceutical manufacturers, I've seen them come up with medication now that we can treat hepatitis C with. That is phenomenal. We can cure it with a pill. And it's because of the research and development that's been done through our pharmaceutical manufacturers and through the National Institutes of Health that we've reached this point. However, the price of those medications in many cases make it inaccessible for people. If you've got to pay $85,000 for a medication to treat hepatitis C, for many people, that's just simply not accessible. And if that medication is not accessible, it does you no good whatsoever. So I've called on the pharmaceutical manufacturers to do their part as well. They're not without responsibility here, and I think they understand that. But tonight, what I want to concentrate on are the PBMs, the pharmacy benefit managers, the middleman, if you will. Now, if you look at their mission statement, they will tell you their mission is to lower drug cost. Well, my question to you would be, how's that working out? If that's working out, if they're achieving their mission, why are we here? Why are we here tonight talking about this? High prescription drug cost. I would submit to you that they bring no value whatsoever to the healthcare system. Madam Speaker, I'm very blessed tonight to have a number of speakers here with us to share their expertise. And I want to hear from some of those right now. I want to begin with the gentleman from Kansas, Representative Roger Marshall, who also is a physician, was a hospital administrator, and knows this and understands this system. And I want to allow him to assume as much time as he may need to make his point.
Thanks to my colleague for yielding. Speaker, I rise today in support of the Trump administration's rule that will modernize Medicare Part D and as a result lower drug prices, reduce out-of-pocket expenses for America's seniors, and make critical fixes to our systems that will help our local pharmacies. Across Kansas, there are 506 chain drug stores and 253 independent community pharmacists. These pharmacists are honest, hardworking people, men and women that often go above and beyond to ensure that patients know how to manage their medications. I've heard their stories, and they all share the same frustrations: direct and indirect remuneration or direct fees. In many instances in rural America, the only healthcare professionals left standing are my good friends and colleagues from the noble pharmacy profession, and these DIR fees are running them out of town. The increase of DIR fees over the last several years has raised out-of-pocket costs for our seniors and put our pharmacies at financial risk, often operating in negative margins. Far too regularly, pharmacy benefit managers, or PBMs, collect DIR fees from pharmacies months and months after the claim. It's completely unpredictable and unfair, while the benefit all goes into the pocket of the pharmacy benefit manager. Shame on them for doing this, but not anymore. This proposed rule will guarantee predictability by helping standardize the process and end the disparity between pharmacists, patients, and PBMs. The Centers for Medicare and Medicaid Services estimated that seniors will save up to $9 billion over the next 10 years and save the federal government nearly $17 billion over that same time frame. I appreciate President Trump and his administration for addressing this concern and providing common sense financial solutions. It's my hope and the hope of pharmacists across the country that this rule will be finalized quickly so that it can go into effect next year. I'd like to recognize my colleagues, pharmacist Buddy Carter, who may know this issue better than any of us, as our only pharmacist in Congress. And thanks to my colleagues, Dr. Phil Rowe, Morgan Griffith, and Peter Welch, also for leading on this issue and bringing it front and center for both the Doc Caucus and the Energy and Commerce Committee members. Thank you, and I yield back.
I thank the gentleman for his keen insight on this subject. It's very important, and appreciate his expertise. Thank you. Madam Speaker, what the gentleman from Kansas was speaking about are two proposals that are before CMS right now. One proposal would do away with DIR fees. Now, make sure we understand DIR, that stands for direct and indirect remuneration. And what this is when the PBMs actually go back, in some months later, in some cases years later, and recoup or claw back reimbursement for what they've already sent to the pharmacies. Now, you can imagine what kind of impact this would have on a business. There is no sustainable business model out there that can absorb that. When you're talking, I get texts all the time from small pharmacy chains who are telling me, oh, I just got a bill from a PBM. Last year, my total costs, my total DIR fees were $500,000. $500,000. That, and that's money you've already paid taxes on. But they're clawing it back. They're taking it back. CMS has proposed that end. I'm in support of that, and I appreciate CMS doing this. The other proposed rule that CMS has come out with has to do with the rebates or discounts, if you will, by the PBMs, that are offered to the PBMs by the pharmaceutical manufacturers, not offered to them, but the PBMs demand them from the pharmaceutical manufacturers. Now what CMS is proposing is that all of those rebates or discounts, if you will, be given at the point of sale. And what we're trying to achieve here is to make sure that those rebates, that those discounts are going to where they're supposed to be going, and that is to the patient. Keep in mind, everything we're talking about here is about the patient. We're talking about patient care. My next guest speaker is also an expert in health care. In fact, he's another one of our members of our doctor's caucus, a urologist from Florida.